Good evening. Welcome to the Wednesday ICA webinar. ICA, as all of you know, stands for Indian College of Anesthesiologists, which is highly academic in its nature and is imparting the educational material and providing opportunities for all of us to upgrade ourselves in the field of anesthesia. It's an absolute delight for me to welcome you to this webinar entitled Hemodynamics, What, When, and How. We have stalwarts in the field to discuss with us about the subject. And I request all of you to put your questions and comments in the chat box such that we'll discuss and answer the questions at the end of the session. Please stay tuned. And with these words, I would like to introduce the moderators, panelists for this evening. First one is Dr. Nibedita Pani. Dr. Nibedita Pani, who is professor in Orissa. She is the professor and HOD of Critical Care and Anesthesiology at SCB Medical College, Cuttack. And she's a very accomplished individual with a lot of credentials to her credit. Next moderator will be Dr. Bhupesh. Dr. Bhupesh is a professor and HOD of cardiac anesthesia at the famous PGI Chandigarh. And again, he is a very accomplished personality. We have a lot to learn from him. Next is Dr. Vidya Patil, who is the professor and HOD Department of Anesthesiology at BLDE Medical College, Vijaypura in Karnataka. Again, a very pleasant and highly acclaimed personality. And last but not the least, we have Dr. Vivek Dave, who is into critical care medicine at the Narayana Health Ahmedabad unit. And again, a very enthusiastic and academic personality. And with these words, I would like to hand over the podium to Dr. Nibedita Pani to conduct the meeting. Please stay tuned till the end because we have interesting questions and discussions. Thank you.
Thank you, Dr. Muralidhar. Welcome to the hemodynamic monitoring and what and when and how session. And today's the topic is the basic hemodynamic monitoring. And the speaker is Dr. Venugopal. He is the professor and HOD anesthesiology, KMCT Medical College, Calicut, Kerala. He is a ISA Kerala GC member and webinar coordinator for the bi-weekly ISA Kerala PG update. Number of publication international 4 and national 10. And guest lecture he has delivered 30. And he has got special interest in the quality control, cardiac intensive care. Sir, kindly deliberate your session.
Thank you, ma'am, for that kind introduction. I hope I'm audible. Slides are moving, I hope. Ma'am, can I start?
Yes, slides are moving. You can start.
Thank you, sir. At the outset, I would like to thank Muralidhar sir and his team at ICA for the opportunity. And today I'll be talking on basic hemodynamic monitoring. Now, the word hemodynamics is derived from the Greek words haima and dynamikos, which means blood and flow. So hemodynamics is concerned with the forces generated by the heart and the resulting motion of blood through the cardiovascular system. So hemodynamic monitoring is the intermittent or continuous observation of physiological parameters pertaining to the circulatory system with a view to early detection of need for therapeutic interventions. Now, one can ascribe the birth of hemodynamic monitoring to the British anesthesiologist, and he was Dr. Clover, because he was the one who emphasized that we should have one's finger on the pulse while administering chloroform anesthesia. The word monitor originated from the Latin word monere, which means to warn. So hemodynamic monitoring which is a cornerstone in the management of critically ill patient, is used to identify cardiovascular insufficiency, its probable cause and response to therapy. So this is the most important thing. It is difficult to document the efficacy of monitoring because no device improves outcome unless it is coupled to a treatment that improves the outcome. So what is the importance of monitoring? Monitoring provides an early warning of adverse changes or trends before irreversible damage occurs. It reflects the physiologic homeostasis. It allows prompt recognition of adverse changes, and it allows prompt recognition of responses to the therapeutic interventions that we perform in the intensive care unit. So, which is the most important monitor? The most important monitor is the anesthesiologist with eternal vigilance. And this is amply embedded in our logo, both of the American Society of Anesthesiologists as well as the Indian Society of Anesthesiologists. So eternal vigilance is the most important monitor that we have. So coming to hemodynamic optimization, the ability to optimize hemodynamics to ensure adequate organ perfusion and improve clinical outcomes is one of the many holy grails in anesthesia and intensive care. But which hemodynamic targets should we aim to optimize the patient? It remains elusive and controversial. So apart from the traditional hemodynamic targets, there are many other hemodynamic parameters that are increasingly available, like the dynamic indices and the central venous oxygen saturation. So what are we actually worried about? We are worried about whether we are going to cause tissue hyperperfusion. And what do we have to really monitor to prevent this? It should be that we should monitor whether we are giving adequate oxygen delivery. So what are the determinants of oxygen delivery? Oxygen delivery is nothing but the product of cardiac output and oxygen content. Oxygen content is dependent on the hemoglobin content, the oxygen binding capacity, and the oxygen bindings of hemoglobin and the dissolved oxygen in blood. Cardiac output is nothing but the product of stroke volume and heart rate, and stroke volume is dependent on afterload, preload, and contractility of the heart. So if we are able to monitor the preload, afterload, and contractility, we should be able to do a good hemodynamic monitoring. So how do we assess adequate oxygen delivery? It could be from clinical estimation by looking at the skin temperature, the prolonged, whether there is prolonged capillary refill, whether the peripheries are cool, whether there is tachycardia, whether there is a reduced level of consciousness, and whether there is decreased urine output. So a good physical examination should be done. Similarly, you can rely on lab values of lactate and base excess. And finally, we can measure the cardiac output and the mixed venous oxygen saturation. So coming to the basic hemodynamic monitoring, the classical hemodynamic monitoring is based on invasive measurement of systemic, pulmonary, arterial, and venous pressures and of cardiac output. Since organ blood flow cannot be directly measured in clinical practice, arterial blood pressure, despite its limitations, is used as an estimate for the adequacy of tissue perfusion. And how do we monitor that? We can monitor it non-invasively by using a BP cuff, and it can be either done automated using the oscillometric method or by your palpatory method by listening to the cough sounds. Now, what are the indications of having an invasive arterial line? It is when you need continuous real-time blood pressure monitoring, when you anticipate pharmacologic or mechanical cardiovascular manipulation, when you require repeated blood sampling, when there is failure of indirect arterial blood pressure measurement, and when you anticipate that you need supplementary diagnostic information from the arterial waveform. So for any invasive setup, you need a pressurized bag of saline, a transducer, and a catheter, as well as a non-compliant tubing which connects the catheter to the pressure transducer. So what is this pressure transducer? Pressure transducer is actually a piezoresistive semiconductor which consists of a diaphragm which is connected to 4 piezoresistors. And these, when the diaphragm is pushed, what happens is the 2 of the piezoresistors are subjected to radial stress, and 2 of them are subjected to tangential stress, and this is in turn connected to a Wheatstone bridge, which will give you a reading of a voltage and which is converted into the blood pressure values. So it's very important that the transducer is located at the phlebistostatic axis, that is the 4th intercostal space in the mid-axillary line. So if the transducer is up, you have a lower blood pressure. If the transducer is placed below this line, you get a higher blood pressure. For every inch that is above or below, you add 2 millimeters of mercury to the real pressure. And the most common arterial site that is used is radial artery. The other arteries that can be used are the ulnar, brachial, femoral, dorsalis pedis and the axillary artery. You can use ultrasound or you can use the palpatory method to put in an arterial line. And it has been classically described as a triangulation technique where the two sides of the triangle is one is the echo probe angle, the echo probe line, as well as the needle path. So both of them are on the two sides of a triangle, and this should intersect at the point of interest. So initially, when you put the probe, it should be slightly standard towards the skin so that you can see the needle entering the skin. And later on, the probe is made more perpendicular so that you can see the entry point into the vessel wall. This is just a picture of the catheter entering into the arterial into the arterial lumen. And we should have an optimally damped system, and this can be tested by using a fast flush test or a square wave testing. You activate the snap or the pull tab on the flush device and look for the number of oscillations after the square wave. 1 to 2 oscillations is the optimally damped system, and if you have more than 2 oscillations, it's underdamped. The underdamped problem is you will overestimate the systolic pressure and the diastolic pressures may be underestimated. If you have less than 1 oscillation, that means it's an overdamped system and there is underestimation of your systolic blood pressure. So the arterial line, it's easy to set up. It's a real-time blood pressure monitoring. There is beat-to-beat waveform display, and the disadvantage is that it's invasive and the complications of risk of hematoma, pseudoaneurysm formation, and infection. Next, we come to the central venous pressure lines. So the indications are a major operative procedures involving large fluid shifts, major trauma, surgical procedures with high risk of air embolism so that you can aspirate the intracardiac air, frequent venous blood sampling if required, chronic drug administration, inadequate peripheral intravenous access, and total parenteral nutrition are some of the indications for placing a central venous catheter. The most common site that we all use is the internal jugular vein, and it is the Sedilot's triangle, which is the landmark for putting in a central venous line into the IJV. And we use the Seldinger technique. It can be done either by the ultrasound probe or by palpatory method. And if you're not using an ultrasound probe, you have to do a Fabian test. It's advisable to use the ultrasound probe because of the anatomical variations, as you can see in this picture here. So that's the way of putting in an ultrasound mediated IJV. Similarly, you can use the subclavian vein for cannulation, and it can be both the supraclavicular or the infraclavicular approach. In the infraclavicular approach, you can use the subclavian shrug technique, where you can ask the patient to shrug the shoulders. And in the shrugging, what happens is the clavicle is lifted off the subclavian vein, which creates a window, and the vein is accessible to ultrasound. Similarly, the shrugging also helps in making a more gentle angle with the brachiocephalic vein, and this should facilitate smooth passage of the wire into the brachiocephalic vein. So there are a lot of advantages and disadvantages of each location. Internal jugular vein, there's less risk of pneumothorax, but there is a risk of carotid artery puncture. Femoral vein, that's having the highest risk of infection, and subclavian vein has the highest risk of pneumothorax, but it happens to be the most comfortable for conscious patients. There are different waveforms for these, for the CVP waveform. The CVP waveform, you have positive waves A, C, and B, and negative waves of X and Y. A is due to atrial contraction, C is due to the pushing in of the tricuspid valve because of the isovolumic contraction. X is due to the X descent is due to the ejection phase, wherein the tricuspid valve along with the base of the heart moves towards the apex. The V wave is due to the filling of the atria, and the Y wave is because of the opening of the tricuspid valve and the emptying of the atrial contents into the ventricle. Now, occasionally you can see an H wave. This is seen when patients have bradycardia with a higher CVP. So central venous catheter, the advantages are easy to set up, and it's good for giving vasoactive medications. The disadvantages are it mostly does not reflect the actual RIP in most situations, and there are multiple complications like infections, thrombosis, and vascular erosions. The third thing is regarding the pulmonary artery catheter. Pulmonary artery catheter was introduced into clinical practice by William Gans and Jeremy Swan. And they were considered as the gold standard from 1970 to around 2000. But from 2000 onwards, the Pacman trial with the ESCAPE trial, there are a lot of complications from PA catheters, and PA catheters fell into disrepute. And there were many publications suggesting that. And 50 years down the line, in 2020, there was an editorial in the European Society of Cardiology. They said that's a very reliable assessment with bedside monitoring, with continuous monitoring and a comprehensive hemodynamic approach. However, because of safety concerns and it requires skills to implant and there is difficulty in interpretation, and because of the advent of echo, this is no more used in the clinical critical care practice because there is no proven benefit. And if you look at the number of PACs inserted over the years, it has been coming down. And we all know that once the PA catheter is introduced into the right atrium, the balloon is inflated and you get the characteristic the CVP trace. And once it enters the RV, there is an increase in the systolic blood pressure. And the moment it enters the PA, the diastolic blood pressures go up, and then you get the wedge tracing. So what are we trying to measure with the pulmonary capillary wedge pressure? Well, it shows you the, it correlates to the left atrial pressure. And if you have a normal mitral valve and the normal left ventricular compliance, ultimately you can estimate the left ventricular end diastolic volume, which is the actual preload for the left ventricle. And ideally, this should be situated in the zone 3 of the west zone. The PA catheter should be situated there because this is one area where the pulmonary alveolar pressure is less than both the arterial and venous, and there is a direct link. And what are the indicators that the PAC tip is in the west zone 3? It is the PA wedge pressure is less than the diastolic pressure by 1 to 5, and the wedge pressure alters less than 50% of the increase in PEEP. So these are some of the X-rays showing you the proper placement. It can either go into the left side or into the right side. And if onto the right side, you should make sure that it doesn't cross the proximal part. It should not go beyond 1 centimeter of the mediastinum. And this picture here is showing you an improper placement where it is placed too deep. And here the patient can develop pulmonary infarction. And if you wedge, it would lead to a rupture. The POP waveform is again similar to the CVP waveform. But it is important that you measure the waveform at end expiration. How do you locate end expiration? With spontaneous breathing, you can locate waveform just before the pressure declines with inhalation. And with mechanical breathing, the waveform just before pressure rise with inhalation. This is shown here. So there are a lot of parameters that we can derive from the PEC. That is the CVP, the pulmonary artery wedge pressure, the temperature of the patient, cardiac output, and we can have derived values like the stroke volume, the systemic vascular resistance, and the the pulmonary vascular resistance. Also, it can be used to find out the cardiac output using the thermodilution technique. And what happens here is you inject room temperature saline into the right atrium, and at the tip there is a thermistor which detects the change in temperature, and the area under the curve is inversely proportional to the rate of blood flow in the PA, which is equal to the cardiac output. So you can see here, if you have a high cardiac output, you have a smaller area under the curve. And if you have very low cardiac output, you have a larger temperature drop leading to a larger area under the curve. And 3 readings are taken together and the average is displayed on the monitor. The next important variable that you can detect is the mixed venous oxygen saturation. And the mixed venous oxygen saturation is, it shows you, it is dependent on the cardiac output, hemoglobin, the oxygen consumption, and the oxygen saturation. And we have a value of around 60 to 70, which is normal. And it has been shown that the central venous and the mixed venous saturation are almost parallel, go together. So you can, instead of using the mixed venous, you can correlate it with your central venous, this one, and you have catheters for that. That is the precept catheter. And you can have some oxygen delivery parameters also from your PA catheter. You can find out the arterial oxygen content, the mixed venous oxygen content, and the oxygen delivery and oxygen consumption. So there are certain conditions where the pulmonary capillary wedge pressure is more than the LVEDP. This is when the alveolar pressure is more than it's when the alveolar pressure is more. This is seen when you have positive pressure ventilation, high levels of PEEP, increased intrathoracic pressure, or left atrial myxoma, or mitral valve disease. It is less than the LVEDP when you have a non-compliant left ventricle, as in ischemia, hypertrophy, or in aortic regurgitation. The possible clinical indications for a PAC are right-sided heart failure, severe left-sided heart failure, cardiogenic or septic shock with multiple organ failure. There are a lot of contraindications. The absolute contraindications are severe tricuspid or pulmonary stenosis, right atrial or right ventricular mass, and tetralogy of Fallot. The pulmonary artery catheter also comes with the continuous cardiac output monitoring, where instead of giving the cold saline or the room temperature saline, here there's an electric filament which intermittently heats the right side of the heart, and the temperature change is detected at the tip of the PAC. There are a lot of complications similar to the CVP complications, and the other special complications are right bundle branch block, a PA rupture, and pulmonary infarction. Another very important thing that you can detect from the arterial line is the probability of giving preload responsiveness, finding out. So hemodynamic management is a constant daily challenge. You should give just the right amount of fluid. How do you decide that? You should know where, in which part of this Frank-Starling curve you are located. If you're in the steep part, you're fluid responsive. With the other part, the flat part, you're fluid unresponsive. CVP and pulmonary artery occlusion pressures are no more considered to be reliable. They are static, and it's just like tossing a coin. So nowadays, you find the changes in arterial pressure during mechanical ventilation. You have algorithms embedded in most of the monitors now, which give you the pulse pressure variation. And if you have a pulse pressure variation that is less than 10, you don't require fluid, but more than 15, fluid is indicated. And the area under the curve is maximum for pulse pressure variation, which is supposed to be most reliable. But this is reliable only when the patient is on a mechanical ventilator and has sinus rhythm. And suppose he's not on a ventilator, you can use either the passive leg raising test as well as the end expiratory occlusion test. But both these require proper echocardiography or some other method to monitor the increase in cardiac output. So ultimately, after finding all these things, there are only 3 therapeutic options left with you. Either you can give a vasopressor, volume expansion, or an inotrope. So if there is vasodilatation, which you can detect by looking at the diastolic blood pressure or your systemic vascular resistance, you give a vasopressor. If the dynamic indices tell that there is preload responsiveness, give fluid. But when do you stop giving fluid? You can do a lung ultrasound and see if there's fluid, then you stop giving fluid, or you can use the transpulmonary thermodilution and you can look at the extravascular lung. Impaired contractility can be detected by using echocardiography, and you can decide whether you want to give a inotrope. So after you optimize your macro circulatory endpoints, always look at the tissue perfusion based endpoints like the arterial lactate and the capillary refill time and the urine output. Always don't forget the clinical examination. So summarizing, you should integrate all the values to solve the hemodynamic puzzle as quickly as possible so that the patient does not suffer. So remember the 5 T's: the target population, select high-risk patients initially. The timing of the intervention should start very early in the preoperative period itself. The type of interventions, you can give fluid, vasopressors, or inotropes. The target variables should be the blood flow variables, and the target value should be personalized. Thank you very much.
Thank you, sir, for your excellent deliberation. Now we must go to the chat box. Any question is there?
Questions will be answered at the end of the 4 talks.
After all the sessions are over?
Yeah, of all the sessions are over. That is the arrangement. Thank you so much.
Okay, sir. Now we will go for the next session.
Dr. Bhupesh, can you invite Satyen Parida?
Yeah, good evening, everyone. I'm Dr. Bhupesh, and the next topic for today's CME is perioperative hypotension and outcomes. And this will be presented by Dr. Satyen Parida, who is professor at the Department of Anesthesiology and Critical Care at a prestigious institute, JIPMER, Pondicherry. His area of interest is cardiac anesthesiology and critical care, and he has multiple awards in his credit. Dr. Satyam Preda, please go ahead.
Am I audible, sir? Am I audible, sir?
Yeah.
Yes, yes, we can hear you.
Right. Thank you. Sorry, I had forgot to unmute myself. So thank you very much, sir. Thank you for the kind introduction, and thank you, ICA, for having me here. So this, of course, is my first brush with the Indian College of Anesthesiologists, and I must confess that I'm absolutely humbled to be speaking before a panel that that has people who probably answer to the query of the who's who of anesthesia science in India. And thanks to all of you there in the audience who have come to attend this session. I hope I'll be able to make some sense out of the data that I'm going to display before you. So this will be the objectives of my lecture. Firstly, to be able to establish a relationship between perioperative hypertension and post-operative adverse outcomes in the context of non-cardiac surgery. We understand that cardiac surgery is a totally different kettle of fish, so we'll not be going to that. I will be attempting to report the strengths of associations for various blood pressure thresholds and postoperative adverse outcomes. I will also, hopefully by the end of the lecture, be able to make a strong case for conducting more and more prospective interventional trials, especially for certain vulnerable subsets of patients, as also for certain organ-specific outcomes. So here we go. The problem with perioperative hypertension has always been that despite anesthetizing patients for decades together, we really have no consensus on actually how this entity needs to be defined. And that's what was actually acknowledged in this rather older systematic review, which seemed to demonstrate that despite that, depending upon how you define hypertension, whether as a certain a decline from the baseline or as a certain absolute threshold value, depending upon whether you took systolic blood pressure measurements or whether you took mean arterial blood pressure measurements, the incidence of perioperative hypertension could be widely variable. And 15 years down the line, nothing much really seems to have changed. Monk and colleagues were some of the first authors to actually demonstrate an association between perioperative hypertension and postoperative mortality. This, of course, was intraoperative systolic hypotension that they were talking about, which was defined as a decline in blood pressure, in systolic blood pressure below 80 millimeters of mercury, but the signals of harm in their study with respect to one-year mortality was extremely palpable, with a relative risk of 1.036 per minute of exposure. So this is about organ-specific outcomes. The authors were looking to relate perioperative hypertension with acute kidney injury. And they found that at two thresholds of mean arterial pressure, at less than 55 and less than 60 millimeters of mercury, for exposures of 11 to 20 minutes duration, the association with acute kidney injury was quite palpable. And although the odds ratios for both of these thresholds were quite different, the results were undeniable. So this also brings into concept this also puts into focus the concept that it's not just the absolute value of mean arterial pressure that matters, but also the overall duration of exposure, much like an area under the curve, actually. So this is again another data set that deals with organ-specific outcomes, very large retrospective data set, more than 30,000 patients. Now we always know that hypertension is associated with poor organ perfusion and organ injury, but these authors were able to put a certain number to that. So they demonstrated that below 65 millimeters of mean arterial pressure, the the possibility, the risk of harm to the kidneys on the left panel and to the myocardium on the right panel go up substantially. This also was from the same authors, from the same study, in fact. And this again integrates, this graph again integrates the concept of having, looking at both the mean arterial pressure thresholds as well as the overall duration of exposure. So if you look at the graph here, even durations of exposure of as little as 1 to 5 minutes at mean arterial pressures below 55 millimeters of mercury were associated with an escalated odds of more than 30% with regard to acute kidney injury and cardiac complications. This was one of the older systematic, one of the rather newer systematic reviews which was published. Again, a very large data set, more than 42 studies went into the ultimate analysis. And the selling point of this systematic review was that the authors were able to place certain thresholds of mean arterial pressure and relate it to perioperative outcomes. So if you look at the panel on the extreme right, which demonstrates the risk of organ injury, the authors were able to show that at prolonged periods of exposure, prolonged durations of exposure, which they defined as greater than or equal to 10 minutes, even mean arterial pressures below 80 millimeters of mercury were associated with definite risk of organ injury. Although these risks, thankfully, were low risk, as evidenced by odds ratios of between 1 to 1.04. That's the area which has been, that's the panel, those are the panels which have been put in yellow. And this low risk for organ injury could be demonstrable even for lower durations of exposure of greater than or equal to 5 minutes when the blood pressure thresholds decline to less than 70 millimeters of mercury. The low risk then became moderate risk, which are the brown panels on the right, when blood pressure thresholds decline to 60 to 65 millimeters of mercury for durations of exposure greater than or equal to 5 minutes, and when the blood pressure thresholds decline to 50 to 55 millimeters of mercury, these moderate risks of organ injury were demonstrable for any duration of exposure. Again, the moderate risk of organ injury became high risk, which are the panels on red, when the blood pressure threshold was below 65 millimeters of mercury for greater than or equal to 20 minutes, less than 50 millimeters of mercury for greater than or equal to 5 minutes, and less than 40 millimeters of mercury for virtually any duration of exposure. So let's take a pause here and think about what this systematic review actually tells us. It tells us that even at blood pressure thresholds below 80 millimeters of mercury, below 70 millimeters of mercury, levels which we have always considered innocuous in the perioperative setting, there still exists a definite risk of organ injury. Thankfully, however, those risks have been demonstrated as low risks, which is some food for thought. So the problem with many of the systematic reviews, as with much of the evidence in perioperative hypertension research, is that most of them are plagued with a lot of heterogeneity. So there is variation in the characteristics of the patients chosen. So the age groups of the patients chosen may vary. There are differences in the kind of procedures that have been selected. Some may be as wide as non-cardiac surgeries, some may be as narrow as thoracic aortic aneurysms, or for that matter, gastric bypass surgery. So no homogeneity to that. And then, of course, there is the problem of a non-uniform definition of perioperative hypertension, which we have already talked about. And finally, even the post-operative adverse outcomes have been defined, analyzed, and reported in variable ways. And the result of all this heterogeneity in the evidence base means that authors often have to resort to various conversions and assumptions in order to be able to merge the definitions of perioperative hypertension as well as the strengths of associations in order to represent the data in a qualitative manner. And fallout of all this is that it's extremely difficult to actually point out a particular cutoff of blood pressure and say, this is the blood pressure that all clinicians need to target below which patients might be harmed. Much of the data, much of the evidence also is from retrospective data. And although retrospective data are good for demonstrating associations, which indeed they do between perioperative hypertension and postoperative outcomes, a causal relationship between perioperative hypertension and outcomes is not forthcoming from the data we have as evidence-based so far. So we talked about variations in the way hypertension has been defined, and therefore it would be interesting to check out whether the methods which have been used to report the severity of hypertension could actually have an impact on the overall strength of association with post-operative outcomes. And this was just such an attempt where the authors used 12 different methods to statistically model perioperative hypertension in order to check out the strength of association with two post-operative outcomes, those of acute kidney injury and myocardial injury. So the 12 methods that are chosen are given on the right. They included such methods like the yes or no method, whether hypertension was present at all or not, the number of hypertensive episodes, the total duration of hypertensive episodes, so on and so forth. 12 different methods were chosen. The authors also chose 8 different thresholds of blood pressure. And 4 of these thresholds were based upon a certain percentage decline from baseline, and 4 of them were absolute values, of which 2 were systolic blood pressure and 2 were mean arterial blood pressures. And after going into all such trouble, the authors concluded that the threshold to define hypertension, as well as the method chosen to model hypertension, actually affects the association of hypertension with perioperative outcomes. And as a result of this, the studies on perioperative hypertension were extremely were less comparable, and the clinical application of these studies, of the results of these studies, were dubious. So this was Cleveland Clinic data, where the authors were actually looking to see whether defining hypertension in variable ways, either as a percentage reduction from baseline or as an absolute value of mean arterial pressure, would actually affect the incidence of organ injury that was resulting from such hypertension. So for purposes of this study, they compared a 25% reduction from baseline, which was compared with a mean arterial pressure less than 65 millimeters of mercury. And the authors concluded that whichever way you define perioperative hypertension, the harm signals were extremely palpable, were extremely strong for all sorts of organ injury, whichever way the definition was made. The problem with defining perioperative hypertension as a certain percentage reduction from baseline, however, is that we really do not know what the true baseline for a certain patient is. Typically, it should be the blood pressure that the patient actually maintains in his domestic existence, in his day-to-day life, carrying out his day-to-day activities, but we have no good way of assessing that. So in the absence of such knowledge, it might be worthwhile to actually fix up a certain value of hypertension, which in this case was 65, certain value of mean arterial pressure, which in this case was 65 millimeters of mercury, and target that, hoping that things turn out good with our patients. So again, another retrospective review, nearly 900 patients from 2 university hospitals, vascular surgical patients, and the authors were checking out the association between perioperative hypertension and myocardial injury. And for purposes of this study, they defined perioperative hypertension as a greater than 40% decrease in mean arterial pressure. And what the authors found was that when there was exposure to a cumulative duration of greater than 30 minutes at these definitions of hypertension, the incidence of myocardial injury was substantial. However, what I found very interesting about the study was this particular graph, which seemed to suggest that patients who had higher mean arterial pressures, higher baseline mean arterial pressures, actually spent much more time in the perioperative hypotension threshold. So what this means is that the hypertensive patients, just the kind of patients that we would want to avoid any hemodynamic perturbations in, given our knowledge about autoregulatory thresholds and all that, they were the patients who actually had greater incidence of hypertension as defined by, as per these definitions of hypertension that the authors have chosen, which to my mind means that, remember that this is a retrospective review study. So this to my mind means that the authors actually were targeting, the clinicians who were involved in the study were actually targeting certain absolute values at blood pressure and not really were they concerned with a certain percentage decline from a reference value. So we have talked so far about retrospective studies. Let us come to some randomized control trials then. And this is one such trial which randomized chronic elderly hypertensives, elderly chronic hypertensives rather, into 3 target mean arterial pressure ranges of 65 to 79 millimeters of mercury, 80 to 95 millimeters of mercury, and 96 to 110 millimeters of mercury. The subjects in this study were all undergoing major abdominal surgical procedures. And what the authors demonstrated was that having the target blood pressure at 80 to 95 millimeter mercury range seemed to work wonders for the incidence of AKI, which was much lower as compared to the higher as well as the lower targets of mean arterial pressure. The incidence of stroke and mortality did not significantly differ between all 3 groups. And although these results are quite impressive, one cannot help comment that the inclusion and exclusion criteria that were taken for this RCT were quite strict, and therefore the generalizability of this RCT, of the results of this RCT for other population subsets may be quite limited. Yet another randomized controlled trial. This was Emmanuel Futier's group, which checked out the benefits of having a protocolized blood pressure management, protocolized in the sense that they used vasopressor infusions to keep the systolic blood pressure within 10% of a reference value. They compared this type of management with what they defined as a standard treatment group, which was basically a reactive management of blood pressure. The clinicians were instructed to react to a drop in blood pressure below 80 millimeters of mercury systolic, or a 40% decline from baseline. And they were able to demonstrate in no uncertain terms that there was at least a 30% risk reduction with regard to post-operative organ injury when they use this kind of protocolized management of blood pressure using vasopressor infusions to keep it within very narrow ranges. Again, one cannot, however, help observing that the standard treatment group with Futier and his colleagues had defined is not really something that represents current clinical care. No one really waits for the blood pressure to drop below 80 millimeters of mercury systolic prior to treating those these days. So I will end up with this slide on postoperative hypertension. Excuse me, it's a very busy slide, but what I want you to focus on are the colored dots on the slides, which demonstrate that not only is this again is from Ashish Khanna's group, which has done a lot of work on postoperative hypertension, and this seems to demonstrate that postoperative hypertension is extremely common in the postoperative period. And that it is substantially associated with organ injury across all organ systems, but most prominently with acute kidney injury. Not only that, postoperative hypertension in this data set was independently associated with organ injury, with organ dysfunction, irrespective of whether there was associated intraoperative hypertension or not. So with or without intraoperative hypertension, postoperative hypertension itself can wreak severe damage. And let's remember that postoperative blood pressures are something which we do not measure as meticulously as we do in the intraoperative period. So that's again something where we have to improve our clinical practice with. So I will conclude with the following take-home messages. Firstly, that there seems to be some evidence that at mean arterial pressures less than 80 millimeters of mercury, there could still be some risk for organ injury, especially when the durations of exposure are substantial, although overall these risks seem to be mild. The risks, however, seem to escalate as the blood pressure thresholds come down and with increased durations of exposure to these lower blood pressure thresholds. Overall, the evidence base is such that there is a lot of heterogeneity with regard to the kind of patients that are chosen for trials, the way hypotension has been defined, and the way postoperative outcomes have been defined as well, because of which it's really extremely difficult to actually designate one particular blood pressure as a safe blood pressure above which we should maintain all our patients. But given all the data that I have looked at, I would assume that 65 millimeters of mercury would seem to be a reasonable range of blood pressure to maintain in most of our subjects, given that below this, the risk of organ injury becomes high risk, if you remember the red panels. However, a more discerning clinician might well disagree with me. And finally, I would make a call for requirement of more prospective interventional trials, especially with regard to certain vulnerable patient subsets and to targeting certain organ-specific outcomes in order to answer questions about perioperative hypertension better. I understand there will be ethical challenges in actually conducting these trials, but I'm sure intelligently designed trials in this regard can be conducted and would be helpful for helping us to guide clinical decision making with regard to this topic in the future. Thank you very much for your patient listening.
Thank you, Dr. Satyam, for a nice elaboration on the topic, particularly highlighting the perioperative instance of hypotensions and the association of this with the postoperative outcome, and also highlighting that there is all those association, but we don't know the causal relationship has not been established so far. And the point to be highlighted again is this: there is no single digit which suits to the every patient, so that has to be individualized. And another issues of like perioperative hypertension definition are still is not clear. So there is the clear-cut data from what we have. There is no clear-cut solution for those. So still we wait till the proper definition and the causal relationship has to be established. So there are few RCTs that has shown a post-operative poor outcome with a different organ dysfunction, but those are few. So with this, we'll end with this talk. And for next talk, we have our co-panelist, Dr. Vidya Patil. She is a professor and head of department at Department of Anesthesiology at Vijaypura. Dr. Vidya, please.
Good evening, everyone, and I thank the organizers of this webinar for the opportunity given to me. We now have the next speaker, Dr. Niranjan Nazi. He will be delivering a lecture on echocardiography as a hemodynamic monitor. So, coming to his introduction. Okay. Dr. Niranjan Nazi is a diplomat, advanced PE and BE. He is a fellow cardiothoracic anesthesiologist from US. He is chief in cardiac anesthesia, Department of Heart Transplant and Advanced Cardiac Surgery at Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. He is also a teacher for cardiac anesthesia fellowship, and he is also a director simulation echocardiography training course. His coveted publications are he has published 2 prospective studies in Annals of Cardiac Anesthesia and 3 case reports in Journal of Cardiovascular Anesthesia, and he has also published 1 letter to the editor in Anesthesia Journal. Over to you, sir, Dr. Niranjan Nazi.
Thank you, ma'am, for the kind introduction. Can everyone hear me? Thank you, ma'am, for the kind introduction. Good evening.
You are heard, sir. You are audible. Go ahead, sir.
Yeah, good evening, everyone. Thank you, ICA. Thank you, Dr. Kanchi, Muralidhar, sir, for this opportunity. I just like to it's a very short time to go through this extensive talk, but I'll try to give a brief overview about how echo can be helpful in management of hemodynamics. Okay, so there are various papers.
Sorry to interrupt you, sir. So can you please make it a full screen? It's not in full screen.
Oh, yeah. Yes. Is it okay now?
Yes, sir. Perfect.
Okay. So there are several papers which have mentioned the role of echocardiography in management of in hemodynamic challenge patients in critical care as well as emergency medicine. Whereas echo can be used to rapidly identify the type of shock. It can be used to titrate your management. It is further used to monitor how your monitor if the management is going the appropriate direction. It can also help to fine tune your ventilatory settings and effectively bring about change in the patient outcome. So earlier in hemodynamic challenging situations, critical situations, the earlier protocol used to be give fluids, start decline, start iron probes, pressors, and at the end, if nothing works, then you used to do the echo. But in the current guidelines, in any hemodynamic unstable situation, the first thing what you do is do an echo. So echo is the first tool that has to be used, is recommended to be used in ICU, ER, peri-op situations where there's hemodynamic instability. And there are several papers there. It should not be used only for the initial diagnosis, but it should also use for continual monitoring. And it should also be used to titrate your change in management, whether it's working in the right direction. There are several types of echo can be used. There are focused echoes. They might be named differently: transthoracic echo, transesophageal echo, lung ultrasound, fast, wait, rush. They're named all in different ways, but essentially they serve the same purpose of finding out what's going wrong with the patient. The focused echoes here in point of care ultrasound has been shown to have a very short learning curve for the basic echoes. Given in a 10-hour course, 84% of the people who are trained in a 10-hour course were able to get their identify equally. The interpretation was equally good to the experienced echocardiographers. 40% of them were able to even titrate the management in the right direction. So primarily what we use essentially, since this talk is primarily with perioperative things, we use the transthoracic echo or transesophageal echo. Comparing the two, the transthoracic echo is easily available. Less expertise is required for that. It is less invasive. Even the patient is anticoagulated, it's less harmful. It's safer to use that. Maintaining sterility can be an issue. However, the problems with transthoracic echo can be if it's a perioperative situation and the surgeon is working out, it might not provide the most sterile of the fields. You might be encroaching on the sterility. There's limited working space available with surgeon operating, and with it might not give good imaging in ventilated patients. Compared to that, transesophageal echocardiography it has better resolution. It's the best modality to interrogate the mitral valve, aortic, anything posterior sector of the heart. It is the choice of this thing to see, and it will give better imaging in ventilated patients. Since it does not interfere the patient field where the surgeon is in the surgical field, it has scope of maintaining better sterility, better working space. The TE sees the SVC better, the transthoracic sees the IVC better. And the only thing about TE is it might not be easily available. It is a little more invasive, and expertise required for doing it, performing the TE. So if you compare transthoracic and transesophageal, most of the findings in 50% of times, whatever findings of transthoracic have been confirmed by the TEE, by the TOE. What in 40%, 35% of people, however, TE has revealed a new diagnosis requiring a new change in therapy. In 12% of those patients, TE determined a diagnosis which the transthoracic echo had even failed to pick it up. So it just clearly shows the superiority of TE over transthoracic in picking out the cause of hemodynamic instability. So one of the commonest causes that it could pick out, which are the segmental wall abnormalities. So if the patient is hemodynamic unstable situation, there is cardiac shock, it can pick out the RWMS and it can act accordingly. The other thing is the cor pulmonale, aortic dissection, the preload of the heart. The other thing it can pick up is the dynamic LVOT obstruction and LA appendage. So as I just mentioned, as all the talks have been mentioned, there are different types. So in a hemodynamic unstable situation, in case of shock, we need to find out what is the problem and address accordingly. So essentially, shock can be diagnosed as an obstructive shock, a cardiogenic shock, the preload, a hypobolic shock with a preload low, and finally, if all three are missing, it becomes a vasodilatory shock by exclusion. However, by echo, we can objectively classify it as a vasodilatory shock. So coming to obstructive shock, the classical scenario when you can have an obstructive shock is the case of tamponade. So here you have a image of a transthoracic echo, any RS systolic collapse. On the right hand side of the screen, you have the mid-papillary view, and you can see this is heart, this is the pericardium, and this echo looks in dark area is the blood collected around the heart. So the quantity may not always matter. It's about the amount, acuity of the event that can cause the tamponade. And tamponade is a clinical event. Any small amount of clot sitting causing RA systolic collapse or RV diastolic collapse, as is seen on the left-hand side picture here, can also lead to tamponade. Second case common is you can see up on top there is the case of pulmonary embolism. Right side there is a video showing a four-chamber view in a TE, and in the video you can see, in the video you can see the clot in the RA. Probably it's got dislodged. In the top left corner is the ascending aorta short axis view, pulmonary artery. You can see the clot in the RPA, right pulmonary artery loaded here, and there's a four-chamber view. Here you can see the RV. This is LA, LV, RA, RV. And the RV, which will be normally less than half the size of the LV, is almost more than the size of the LV. So it just shows that RV is compromised in acute pulmonary embolism. So this can be a common scenario of pulmonary embolism, even while the general anesthesiologists are managing the cases in probably the orthopedic cases, where they can land up in such a situation, and echo can be of help. So this is another situation, which is a cardiac surgical patient, and after coming off bypass and coming in ICU, they had is a hemorrhagic instability situation. So you can see here what's happened is this is a mid-esophageal long axis view. This is LA, LV. This is the mitral valve. This is the aortic valve here, and the aorta. This is a prosthetic valve here. This is a perceivable supralex valve which was put. It has gone. It has been malpositioned accidentally into too deep into the LVOT and preventing the opening of the mitral valve here. So we had to go back on pump to rectify the position, and things were sorted out. So obstruction need not be only static; it can even be dynamic obstruction. So on the left-hand side of both the images are of mid-esophageal long axis view of the TE. This patient had hypertension, blood loss, and there was for the hypertension, adrenaline was started, and surprisingly, pressure dropped even further. So no one knew what was happening. Excessive adrenaline causes excessive tachycardia and further worsen the situations. So when echo was done, what you see is on the left side of the screen. You can see this is LA, LV, mitral, aortic valve, and this is the LVOT where the arrow is pointing. It causes turbulence of flow. Similar image in a normal patient, the flow occurs is a non-turbulent flow. You can see homogeneous orange and blue out here. So what was happening is a dynamic obstruction. It was a case of asymmetrical hypertrophy, concentrated hypertrophy of the LV, and which gets in a tachycardic situation where the LV gets underfilled, or in hypovolemic conditions where you have a lot of volume loss. Starting adrenaline would not having the appropriate choice in this situation. So the treatment of choice where we went down on the adrenaline, gave lots of fluid, started pressors, and the patient was successfully weighed out. So this just goes to show the importance. Just starting adrenaline and inotropic vasopressors blindly may not always help in all situations, and in fact can worsen some situations. So this is a classical scenario. You can see this is the aorta. This is the aorta and a long axis view, and there's a flap out here. This is a descending aorta short axis view, and there's a flap out here. So this is a classical case of aortic dissection picked up in the ER, and the patient goes earliest to the OT to get it rectified to prevent further deterioration of hemodynamics. As you can see, the echo has helped here. The next you can see is the cardiogenic shock. We can just place some here. There's a four-chamber view on the left-hand side here, LA, LV, RA, RV. This is RV is smaller than LV, that's fine. But if you can see the LV is a little ballooned out and bigger, and there's a lot of stasis in the LV. This is called spontaneous echo contrast, and there's an indicator of a poor LV, dilated underfunctioning LV. On the right-hand side is a mid-papillary view. You can see here, this is the LV, and this is interventricular septum, and this is the right ventricle. If you focus on the contractility of the segments, in the directions wise, this is anterior, this is inferior, this is lateral, and this is septal. This is septum on the RV side. So we can clearly see that all the segments of the LV are not moving equally. This anterolateral and septal part are moving well, and the inferolateral parts are not moving well. So this is a classical case of regional wall abnormalities, new onset, post bypass surgery, and we had to go where you would have to address the condition accordingly for this. So what I'm trying to give you, since the audience is primarily non, possibly primarily non-cardiac, I would like to rather than going into excessive details of each procedure, each maneuver, I would like to just put forward how echo can be used qualitatively, just by 2D imaging to bail ourselves out of any hemodynamic instability, unstable situation. And it's not too difficult to think. By just merely doing 2D imaging and a little color, you can identify things. So the earlier slide, this here was qualitative imaging. If you go quantitatively on the left hand side of the screen, here the top two help in calculating the volumes and diastolic volume and systolic volume. And if you subtract the two by a formula, you get the ejection fractions. The left hand, the top, these two bottom images, you can quantify them. The mid-papillary view, this is in systole on the right, this is in diastole on the right. You trace the borders, you get the fraction area change in diastole and systole. And by applying the formula, you get the fraction area change, which is a surrogate marker of the ejection fraction of the ventricle. And the right hand side is red dots and all are the classical examples of the global longitudinal strain. Anything less than 20 or less would not indicate of a normal LV function. Also, the pattern of the strain would give us enough hints to the type of pathology we are encountering with. This next slide here is a case of classical, again, the four-chamber view. This is LA, LV, RA, RV, what you've seen. The difference here is the right ventricle is much enlarged, is much more bigger than the LV. Also, you see that this is the septum, which should be normally bowed to the right side, is now bowing into the left side. So this is a ghastly critical situation where the pressures, if you keep on filling the, which will cause a very critical situation if not addressed appropriately. On the right-hand side, where the same thing is the long axis view, LA, LV, this is the mitral valve, this is the aortic valve, and the flow in the aorta. Normally, this should be seen as a small chamber. This is the right ventricle, is ballooned out into the LV. So both are classical examples of right ventricle failure. This can happen pulmonary embolism. There can be pressure overload, like in the case of pulmonary embolism. Or there can be a volume overload as in a massive TR. So this can be identified by the septal motion, as you have seen here. The septal motion. If septum is bowing into the LV side in systole, it indicates a pressure overload, possibly pulmonary embolism. If it's bowing in the diastole, it is indicative of massive volume overload, possibly massive TR. So it helps us in any case of cardiac shock. The basic principles remain the same: decrease the preload, decrease the upload, increase contractility. However, by differentiating, without the echo, we would not know whether there's left or right failure. And by differentiating between left and right failure, probably in RV failure, we will start more of an inotrope. The choice of inotrope would be middle known, since this drops the pulmonary vasculature resistance much more than the other agents. You might keep a very low CVP. CVP is not a great guide of fluid responsiveness. However, it would be helpful here to see the RV preload and use nitric oxide to decrease the pulmonary outflow. So by echo, you could not only diagnose cardiac shock, but it also differentiate between the left and right heart failure and treat the patient accordingly. This was a common scenario for even patients, those people managing liver transplants. So this is the next slide. Is earlier slide that was a qualitative assessment of RV. This is a quantitative assessment of RV. On the top side, on the bottom here is the M board showing the TAPSE, the tricuspid annular plane systolic excursion, which should not be less than 17. And on the top here is the S prime, which is the tissue Doppler. And this S prime is above the baseline. It should be not less than 9. Anything less than 9 would be indicative qualitatively about the poor RV function. On the right-hand side, you see the RV strain, which also corresponds to the patient outcome. So apart from the qualitative assessment, echo just can be used for quantitatively as well. Echo can be used as any other cardiac output monitor. How do you do that? So the basic principle of area into flow. Flow is the VTI, velocity time, the calculation of the velocity of flows across that area, that particular area is a VTI. We get a VTI, velocity time integral. So if we calculate the area of this point and the flow across, the VTI across, we can calculate the flow occurring across this point. So the point what we decide is LVOT. This is a mid-surgical long axis view. This is LA, LV, mitral, and aortic valves. So these views are almost the standard view. So you don't need to know all the views. Basic 4 or 5 views can be used to bail us out of many situations. This is standard mid-surgical long axis view. Okay, here, which will help you calculate the LVOT diameter. Assume the assumption here is the LVOT is a circle. We calculate this diameter and gives the area is calculated by pi r square. And if we go to a deep transgastric view to get the velocity here, and there's the velocity we ought to get is a VTI, velocity time integral. When you get a velocity and you trace this, the flow, the velocity here, you get a VTI. Area pi r square into VTI will give us flow. The flow is the stroke volume. Stroke volume into heart rate is the cardiac output. And by application of this formula, SVR is MAP minus CVP, mean arterial pressure minus CVP upon cardiac output, you get the systemic vascular resistance. If the SVR is low, you start pressors, it's a vasoplegic shock. If it's high, you might try to go down on the pressors or use some vasodilators. So we choose the deep transgastric view because we had to have perfect alignment alongside the flow for better accuracy. So this is a deep transgastric view, and if you the flow across is exactly parallel to the cursor, and that is why this view is selected. And the tracings here are the VTI, velocity time integrals, which I'll be speaking on in subsequent slides. The next situation is a hypovolemic shock. There are two terms which are important now to understand are fluid status and fluid responsiveness. Fluid status means the total amount of fluid, the content amount of fluid that would be the central vascular system. Fluid responsiveness is a term which can precisely tell us whether if you administer fluid to a patient is going to be responsive. So you administer fluid and the stroke volume increases by 15%, that means the patient's fluid responsive. So this terminology has been coined because if you give excessive fluids unnecessary to a patient, that has impacted outcomes and a more ventilatory and ICU stay. On the other hand, if you give too less of fluids, it can impact your renal and other organ functions. So normally the parameters of fluid responsiveness are divided into volume-based parameters and pressure-based parameters. Also, they can be divided. The volume-based parameters are better than the pressure-based parameters, and the dynamic parameters are better than the static parameters. So whether it's pressure-based parameters, volume-based parameters, both are static and dynamic, and the volume-based parameters and dynamic are the most accurate parameters. So the echo also can give us static as well as dynamic parameters based on echocardiography. So if you see on the left-hand side, there's a mid-papillary view. This is commonest view again, we are seeing again and again. This is a LV, this is septum and the RV. On the left-hand side, if you can see the septum, all the walls of the LV are kissing. This is called a classical kissing ventricle. And the right-hand side is a normal contractility. So this is static view saying the state, indicating the fluid status. So it's not the best view to identify fluid responsiveness, but it is definitely a good view when the LV is empty to understand the LV is empty. On the left-hand side, we can focus the LV is totally empty, all the walls are kissing each other, and you can definitely administer fluids. In the next slide, there is a pressure slide. So the pressure parameters by echocardiography. On the left-hand side, on the top, you have the transmitral, pulse width Doppler and transmitral gradients. You get an E and A wave corresponding to the early diastolic filling phase and the late diastolic filling phase, and that can indicate your grades of diastolic dysfunction. On the lower is the tissue Doppler, where you put the pulse width Doppler on the lateral mitral annulus, and you can see how much the ventricular relaxation during the diastole. This is called E prime. So E by E prime, when this is the E wave, we get a value. E prime below, we get a value. The ratio E by E prime is an indicator of LV, EVP, LV, and diastolic pressure. So whatever parameter information is given by the PA catheter, what we want from PA is the LV, EVP, LV, and diastolic pressure. So that can be achieved by echocardiography. So we have many devices like flow track and etc. Using SVV, PPV, and indicating fluid responsiveness. So they are non-invasive and they're good. So they say more than 20, 15 number, they give fluids. Less than 15 or less than 13, as the number goes down, you should not administer fluids. However, they don't focus on the number. So if you have a PPV or SV number of 8, 7, 6, you don't know whether you have the fluid is in, you know not to give fluids, but they don't indicate accurately whether the fluid content is excessive and you need to administer diuretics. However, in echo can help us in this condition. So if you have use the static parameters, pressure-based parameters here, and find LVADP, and you don't know if the LVDP is high, you know the pressure is excessively high, on the volume status is on the higher side, and you might administer diuretics. First of all, you stop giving fluids, and you may necessarily required to administer diuretics. You can confirm similar thing on lung ultrasound and see the vertical lines. Normally, in lung ultrasound, you do not see the vertical lines. Vertical lines are the B lines. Normally, you would see the horizontal lines, they call it A line. If you see multiple B lines and confluent lines, it's a very good indicator that you need to probably diurese the patient. And these B lines would arise much earlier than your oxidation will fall. On the right-hand side of the same slide, you can see that this is the bicable views. This is the LA, RA, SVC on the right side, IVC on the left side. And so if you put a mode here, you can see the collapsivity of the SVC. So SVC is an interthoracic organ and can be well evaluated by the TE. And the SVC sensibility and variability is more accurate than the transthoracic echocardiogram that measures the IVC. So IVC also can have a dynamic index that can pick up the ultrasound, which is the IVC distensibility, IVC collapsibility, and SVC distensibility. So these numbers, the distensibility indices, which is we get a maximum diameter and minimum diameter. And then you apply a formula, max minus minimum, upon the mean or the minimum, to give you a number. And depending on the number is high, you give fluids. If the number is less, you do not give fluids. So these are dynamic indices which are given provided by echocardiography, which are low learning curve, which can be safely applied to help us guide fluid therapy. So this is next slide is about the dynamic indices of fluid responsiveness, as I have spoken earlier in the earlier talks. So because of the heart-lung interactions, there is variation of stroke volume, and then that has picked up accurately by a monitor, and it can be in the form of PPV pulse pressure variation or SVV stroke volume variations, which accurately detect, which are equal amount of accuracy to tell us which are very good indicators of fluid responsiveness. For stroke volume, SVV, we need a cardiac output monitor. For PPV, we just need arterial tracing and the variation and a number. However, the patient here has to be ventilated with 8 ml per kg tidal volume, controlled ventilation, and he should have a sinus rhythm. So, if you have an echo, if the patient is not in sinus, patient is spontaneously breathing, we can use echo to our advantage, and we can use echo to our advantage. So this is the formula of dynamic indices, as I mentioned before, of the SVC collapsibility index and the IVC distensibility index. Echo can provide similar dynamic indices. As you are seeing, you see on the left-hand side, you see the deep transgastric view. This is the LV here now. This is the mitral valve, and this is the LA. So LV inflow is this, and LV outflow is this, and this is the aortic valve. So left ventricle, aortic valve, LVOT, and aorta. This view is selected because the flow here across the LVOT is exactly parallel to this cursor for accuracy. You put the cursor here, you put a pulse width Doppler, and you get a VTI, velocity in time indicator, as I had spoken you earlier about. If you trace the VTI and you trace all the readings, each flow is equivalent to the stroke volume of the patient. And if you see the variations of each of these tracings, you'll get an index, and it's similar to the SVV stroke volume index. So tracing each of the tracings is a tedious task. So you might each tracing, if you trace, you get a VTI variation. index, but it is a tedious task. You might choose to just see the maximum velocity here. So you might just choose to see the maximum velocity, peak velocity here, and it will give the VTI max variation or aortic Vmax variation. So lung ultrasound, as you all know, can be helpful. We can picked up by transthoracic echo to point out B lines, A line, how much to fill or not to fill. So there are recent papers which show that trans-esophageal echocardiography can be used beyond to get information beyond the heart. So normally this is an A, B. This is a first set of readings, second and third. If the probe is on the top of the aortic level, this and the second set of readings at the mid-esophageal foretemporal view level, and at below is a deep transgastric level. And if you turn the probe to left and right and interrogate the left and right pleura. So what we can get what information we can get out of this? If you see this, you can see the lung sliding here on this video. This is the lung sliding. What you can see that means that's normal, and you can see multiple vertical lines. So this just indicates it's the cardiac surgical patient. Indicates that we are on the higher side of the flying starting curves, and we might need to give a little PEEP or administer a little diuretics. We would, however, have to further confirm with diastolic indices of diastolic dysfunction. So that way we come to know that whether to give fluids, whether to ventilate, and with the PEEP, and that has had a positive impact. And this graph just shows using TLS is trans-esophageal lung ultrasound guided administration of PEEP and diuretics has had improved impact in earlier extubations in the ICU. Also on the right hand side, you can see an image where this is a liver, this is a diaphragm, and a collection of right pleural effusion. Here, this is the equivalent area in the this thing. If it's post cardiac patient, if there's a massive collection, it can easily give us the cause of the collection. So transesophageal utterance, this is what we are finding. The transesophageal ultrasound has been used for not only cardiac, now when extend cardiac, but non-cardiac causes, and not only thoracic, but now it has been extended. Utility has been extended even to abdominal causes of abdominal causes of hemodynamic instability, like a hemoperitoneum. So what you see now is not this is not a liver. This is not a lung, which is pneumonic lung. This is a liver here. This is a diaphragm, and this is a massive collection of hemoperitoneum on the left lobe of the liver, or the right lobe of the liver. This is the left lobe of the liver, and massive collection here. You can see the dark line here is the diaphragm. So what happened is there's a massive, when you go to a deep transgastric view, you normally antiflex to see the heart. If you retroflex, you interrogate more of the abdomen. And normally this liver is in a close approximation to the diaphragm. But if you see this gap here, it just indicates that there's a lot of collection there. Patient was subsequently underwent an ultrasound abdomen and was moved to the OT for an emergency exploratory laparotomy with a successful outcome. PE echo is also useful in cardiac arrest. So what you do is TE, especially the transfers while giving chest compressions, you won't be able to do transthoracic echo. But if you have a TE probe slipped inside, what it does is it helps us to identify whether the LV is shows us the LV here, and is the LV is adequately compressed. Secondly, it tells us normally when you mid-sternum, if you apply pressure, it need not what you need to compress is the LV and not LVOT. Many times, as is seen because of this echo in cardiac arrest, the T is there, the appropriate point of compression is not generated. That might not give us effective CPR. So by T guided perfect compression of the LV, we can have more effective CPR, and earlier ROSC is achieved. Quality of CPR is improved. Not only that, if there's it can also be of diagnostic utility, as we have seen. If you see a lot of collection around the heart, it can help us to identify the 6 atrias and the tamponade, and accordingly proceed to a good outcome. It is a prognostic indicator as well. Like if there's tamponade, that's a good outcome. If the initial TE, if there's a cardiac standstill, those resuscitation may not be successful always. Lastly, the TE echo can also be used in eCPR. Suppose you have acute ROSC and the heart is still not adequately pumping, but you have acute ROSC. You can use a TE. You can use the TE for the ECPR, where you put this, let us remain there, and it can let you guide the venous echo cannulation. On the left-hand side, you see here there's a bical view in the center, LA, RA, and the guide wire here. On the left top, you can see the cannula coming from the IVC and the venous drainage cannula for a VA ECMO. The tip has to face the SVCRA junction, and there are multiple ports to drain the blood. So appropriate positioning of the venous drainage cannula is of paramount importance while doing this thing. On below, this is a video below. What you see is the Avalon cannula, with a single lumen cannula for the VV ECMO, for which the T is of paramount importance to identify the correct placement where the outflow channel of that cannula has to face the tricuspid valve. That's what you see in the image. On the right-hand side, you can see is a deep transgastric view, and you can see the IVC. This is the hepatic veins. The appropriate positioning of cannula has to be confirmed in a venous drainage cannula in a VV ECMO. It should not be obliterating the drainage of the hepatic veins. Finally, in instable condition, echo can help you guide the IBB placement. Not only it can help you guide the placement of wire, as you can see here, it can also help you to confirm the position of the IBB. On the left-hand side, simple view before starting, if you get a mid-severe long access view, on the top there, you can see upon MR, there's a little AR there. There's a little AR there. So in excessive, moderate to severe AR, a higher degree of AR is a contraindication to IBP. So the early echo can also help you choose whether you should need to use IBP at all. Thank you. So there was extensive thing that brings to the end of my talk. There was extensive thing to talk about on this, but I would given the limitation of time limit, I would just wanted to give you a brief overview of where echo can be applied, and it's not a difficult thing to do. By mere qualitative assessment, it can help us to bail us out in critically hemodynamic instable conditions. Earlier, it was done by cardiologists, then by cardiac anesthesiologists, and now it should definitely be taken up by even the general anesthesiologists, intensivists, and ER physicians. That's here I would like to conclude. I would be happy to take any questions at the end of the session.
Thank you, Dr. Niranjan. It's a wonderful session. Is Dr. Muralidhar is there?
Absolutely.
Am I audible?
Yes, yes. Can you hear me?
Yes, yes.
I'm absolutely here. I'm waiting to start my talk. I'll do it in a little while. I'm just, can you see my screen there?
Yes, yes.
See, there are some 4 questions which are highlighted here. We wanted to make it as an audience poll, but the organizer said that it's not possible. So I request each of the panelists to address the questions at the end of my talk. So the first question is, all of the following are dynamic indices of preload, except you have to identify which one is not correct in that as a preload indicator. Second is, it will be discussed at the end of my talk. Please wait. Please, this for audience to note. Second question is, IABP inflation is triggered by dicrotic notch, anacrotic notch, systolic pressure or diastolic pressure. Third one is flow track measures all of the following except which one it does not measure. You have to choose from that. Fourth one is extravascular lung water may be determined by one of the following techniques. Is it flow track? Is it esophageal Doppler? Is it IVC diameter or transpulmonary dilution? With that, I will begin my talk. And I would like to thank the ICA for providing us the platform. To begin with, I would like to say that achieving hemodynamic stability, where both macro and micro circulation is doing well during high-risk surgery and in critically ill patients, is a formidable challenge. In fact, we have several parameters, both invasive and non-invasive, that guide us to administer fluids, vasopressors, inotropes, etc. And we have a concept of the goal-directed therapy, which utilizes these monitors to assess the cardiovascular system and guides us to intervene as necessary. But are we doing justice by going by one parameter? In fact, Dr. Satyen Parida mentioned that 65 millimeters of mercury mean arterial pressure is probably suitable, but we will just see how each patient is different. I'll be just touching upon physiology, what is autoregulation, what is protocolized versus personalized management, and at the end, we will see whether one size fits all. When we are targeting hemodynamic parameters, there are two main parameters, that is the perfusion pressure and what is the oxygen delivery. What is the perfusion pressure and what is the oxygen delivery? That is how much blood is going at what pressure and how much oxygen it is carrying. These are the most important parameters for optimization of hemodynamics. So perfusion pressure, which is determined by the mean arterial pressure minus the central venous pressure, dependent upon cardiac output and vascular resistance, and cardiac output in turn depends upon the heart rate and the stroke volume. When you come to oxygen delivery, it depends upon the arterial oxygen content, which in turn depends upon the hemoglobin, what is the PaO2, that is P small aO2, and what is the oxygen saturation. Coming to some of the basic definition, oxygen content is amount of oxygen carried by hemoglobin plus the dissolved oxygen, which is about 20 ml per every 100 cc of blood. And the mixed venous oxygen content again is similar to the arterial content, except that we are using mixed venous blood here. The hemoglobin saturation, the amount of oxygen carried by the hemoglobin in the mixed venous blood, and the dissolved amount of oxygen in the mixed venous blood will give us the oxygen content of the mixed venous blood, and the difference is about 5 ml for every 100 cc of blood. Oxygen delivery is about 1000 ml, and it can be expressed as ml per minute per meter square, which is about 500 to 600 ml. This already I mentioned, the oxygen content difference of the arterial blood vis-a-vis mixed venous blood is about 5 millimeters, 5 ml per every 100 cc of blood. And oxygen consumption is the rate at which oxygen is removed from the blood by the tissues. What is important is when you talk about critically ill patients, this relationship between the oxygen delivery on the horizontal axis and oxygen consumption on the vertical axis, there is a critical point at which, when the delivery of oxygen falls below that critical point, shock state ensues with increasing lactates and diminishing mixed venous oxygen saturation. When you come to the perfusion pressure, within an individual, the perfusion pressure is different for different organs. This we must understand. Not only there are individual differences, but within the body, each of the organs needs a perfusion pressure which is peculiar to its needs. For example, if you take the heart, we need the diastolic blood pressure, whereas in all the other organs, the mean arterial pressure. And in the brain, we have to know what is the intracranial pressure. For the kidney and bowel, we need to know what is the intra-abdominal pressure. So there is difference of how the blood is perfused in a given individual when you come to each of the organs. This relationship shows the shows the relationship between the organ perfusion pressure and the organ blood flow. And the blue line represents the autoregulatory curve. And you can see that when the autoregulation is operational, that is between 50 to 150 millimeters of mercury mean arterial pressure, the vessels either dilate or constrict and keep the blood flow constant irrespective of the blood pressure level when it is between 50 to 150 mean arterial blood pressure. This is the classic depiction of the cerebral autoregulation. We have the lower limit of autoregulation and upper limit of autoregulation, beyond which the blood flow becomes passively dependent upon the blood pressure. This curve has been determined in human volunteers. And what is important is that when we give anesthesia to patients who are diabetic, hypertensive, have cerebrovascular disease, atherosclerotic disease, on the top of that, if you are administering sevoflurane, sodium nitroprusside, nitroglycerin, the autoregulatory curve will be altered. Suppose you have given nitroglycerin infusion and you cannot expect the autoregulation to work when you are giving a vasodilator. So these things have not been highlighted in the literature, and the way we manage patients influences the organ perfusion. For example, the autoregulation limits in a given patient may be narrow. For example, a hypertensive individual, his autoregulation is shifted upwards and to the right. And how to determine it clinically, there is no parameter by which you can go except to some extent, we can use the cerebral oximeter to determine the autoregulation. For example, you can equate the cerebral blood flow to the cerebral perfusion, which can be detected by the cerebral oximeter, which is what is shown in this diagram. This is the oxygen saturation of the brain using NIRS, that is near infrared spectroscopy, and the cerebral perfusion pressure. And this relationship can be depicted or defined as cerebral oxygenation index, which is represented as 0 or 1. As long as this index is 0, it means that the oxygen supply to the brain is all right because of the autoregulation is maintained. Let us take the example of two patients. In this patient, we have the mean arterial pressure represented here, and the cerebral oximetric saturation is measured here, represented here. So in this patient, as the blood pressure, which is mentioned here, falls to 70, 50, and even 40, the cerebral oxygen saturation is maintained, which means that this patient's autoregulation is preserved within a wide range of blood pressure limits. Whereas if you take this patient, as soon as the blood pressure, mean arterial pressure came down less than 70, there is a decrease in the regional oxygen saturation. So this patient must be managed within this range of mean arterial blood pressure. So the two candidates, though going on identical surgery, have different requirements in terms of mean arterial pressure. And I think I'll skip this for want of time. These are some of the evidences which show that the goal-directed therapy works. But now we know that goal-directed therapy, especially in critical care units, there's no difference between early goal-directed therapy and usual care. usual standard of care. This was already mentioned by Satyen, so I will not repeat this. And if you look at this recent guidelines for the management of heart failure with reduced ejection fraction, if you may please notice that in African Americans, the guidelines are different. You can use hydralazine and nitrates in those patients, but not if you are not an African American, which means that there are racial differences. Similarly, if you use the standard blood pressure management vis-a-vis personalized blood pressure management in high-risk patients undergoing major surgery, patients who had standard treatment vis-a-vis individualized treatment based on their resting blood pressure, the outcomes were much better. This is the rate of organ dysfunction compared to the individualized treatment vis-a-vis standard treatment. So the organ dysfunction was much less in the patients who had individualized treatment. We also have proposed that in the approach to non-cardiac surgery in cardiac patients, this was published in the Journal of Cardiothoracic and Vascular Anesthesia 2 years ago. We have suggested that Asians and Indians are more vulnerable to cardiac disease, and cardiovascular disease is very rampant in these parts of the world. And that's why we suggested that ECG, chest X-ray, echocardiography must be included in the algorithm, and one size does not fit all. For example, there are several people sitting here, maybe 1,000 people sitting here, and each one is different. As is shown here, there's no similarity between the height or weight, and everybody is different. And when you look at the clinical trials, we get the mean values. This hides the individual differences. Please note this. The most powerful form of trial, the randomized controlled clinical trials, was devised as a means of determining treatment's effect in a particular group of patients. But there are individual differences. You are only looking at the mean values and average values. So you will not come to what is happening to the individual patients. For example, in a village of 2,000 people, all the individuals there submitted their photographs, and these photographs were merged using software, and you got an average individual here. This person is the average individual, which was determined or obtained by merging all the photographs. And this photograph has no resemblance to any of these photographs. Please note this, which means that what we say as average may not be applicable to any other individual in the community. And I don't know, you can see the audio there. We have developed a polygenic risk score for determination of vulnerability of the patient, person,
and high blood pressure
to coronary artery disease.
Diseases such as coronary artery disease or CAD. The risk of CAD and heart attack among South Asians is 3-4 times higher compared to Caucasians. Young onset CAD or CAD affecting people younger than 45 years of age is getting more common these days. Current approaches used to diagnose heart disease can detect the problem only after the symptoms have appeared. What if we could identify people with higher risk of heart disease much before the symptoms appear? Scientists have realized that our risk of diseases such as CAD are not influenced by 1 or 2 genes, but multiple genes working in tandem. An individual's predisposition to disease is impacted by millions of inherited genetic variations found scattered in their DNA, called single nucleotide polymorphisms or SNPs. On its own, each SNP contributes just a small risk, but when added together, they can make a big difference to the overall risk of disease. Polygenic Risk Score, or PRS, integrates these variations into a single metric. This metric shows if you are at high, moderate, or average risk of CAD. Using PRS, clinicians can then recommend exercise, diet and medication to prevent the onset of the disease much before the symptoms appear. Scientists at India's leading genetic testing lab, MedGenome, have validated the PRS concept on the Indian and South Asian population and have come up with a simple blood test called CardioGen. The CardioGen test is based on a study done by researchers from MedGenome and other leading institutes across the country.
I just wanted to put this across because there are genetic polymorphisms which are existing, which will dictate how a patient or person reacts to a given stress. So this can be tested in the laboratory, and we can predict what is going to happen to a patient when subjected to a given stress. And to end my talk, we should understand that one size does not fit all. Protocolized and personalized hemodynamic management is an example for precision in hemodynamic monitoring. 5 T's of perioperative goal-directed hemodynamic therapy, as elucidated by Dr. Satyen Parida, must be taken into account. Artificial intelligence and big data will help us to personalize treatment strategies and improve outcomes. Precision in hemodynamic monitoring is an essential part of perioperative personalized hemodynamic management of patients. If you look at what one size fits all, I think the classic example is the sari, which is worn by Indian women. But even here, see that there are individual differences. The way it is worn is different by different individuals. Please note that there are individual differences, and making a generalization may not be correct thing to do in a given set of population. With this, I would like to thank you. And we are opening the session for question answers. And I'm just unsharing my screen so that I request all the panelists and speakers to switch on their videos so that we can speak to them and see them and speak to them and address the chat box questions. So now the floor is open to Dr. Nibedita, Pani and other panelists to carry out the question answer sessions. And also in a couple of minutes or so, we will address those questions which were posed at the beginning of my talk. Thank you so much.
Thank you, Dr. Muralidhar.
Thank you.
There are
Thank
few
you so much.
one question is there. How to adjust a AV delay in sequential pacing in post-cardiac surgical patient? Is it always regarding MAP? I think
How to adjust the AV delay?
How to adjust the AV delay in sequential pacing?
Very nice question. Anybody would like to take the question? I have a reasonable good answer for that. How to adjust the AV sequential AV delay is usually kept at 120 milliseconds because that is the time taken for the AV nodal conduction. We keep it at 120 milliseconds. But also you can look at the LVOT VTI or ejection fraction, especially LVOT VTI. And wherever you are getting the maximum LVOT VTI, that should be the optimal time interval for that particular patient. So you can start with 100 and go on increasing it up to 140, 150. And the place where you get the maximum LVOT VTI may be the suitable AV delay for that particular patient. Usually by rule of thumb, we keep it at 120 milliseconds because usually we maintain a heart rate of over 80 to 90 beats per minute.
Thank you, sir. Another question is there. Is there a relationship between the type of surgery and the perioperative hypotension associated with organ damage? I think Satyen.
Yes,
Yeah,
Satyen.
I did put an answer to that, but I would welcome sir's comments on the same.
I think there is a relationship between type of surgery hypotension, perioperative outcomes. Hence, it is vital to, when a patient is undergoing non-cardiac surgery, the simplest thing to do is to go through the revised cardiac index. If the patient has ischemic heart disease, if the patient is having cerebrovascular accident, or a patient has a history of congestive heart failure, diabetes on insulin, renal dysfunction, major intracavitary surgery above the inguinal ligament, all these things are the risk factors which predispose the patients to hemodynamic perturbations and major adverse cardiac events, which are related to the perioperative MI. Having said that, we also have what is called as myocardial injury in non-cardiac surgery, means which occurs where there is cardiac biomarker elevation without the classical features of ischemic myocardial infarction. There is no STT segment changes or regional wall motion abnormalities, but the cardiac biomarkers are increased, and these patients have a mortality of anywhere from 5 to 10% in 30 days time. The 30-day mortality is high in these patients. So here the causative factor for this is the occurrence of intraoperative hypotension, as was highlighted by Satyen Parida's talk. Satyen, you can add on points on.
Yeah, I think the same was also demonstrated by the that study on ACE inhibitors.
Yes.
I forgot the name of that study. Where the incidence of mortality actually peaked on the incidence of myocardial injury, sorry, not mortality, peaked on the first post-op day. The Vision study, which actually was conducted on continuance or non-continuation of ACE inhibitors, which came up in anesthesiology, I think 2017 or 18 maybe. And there, if you look at those graphs, the incidence of MINS actually shot up on the first zero post-operative day. Right. And I think a major contributor to that outcome is intraoperative hypertension. So, what I think what Dr. Bhaskar was asking is whether type of surgery itself is an independent predictor for greater organ damage when identical amounts of hypotension occurs versus less invasive surgery. I mean, the way he put it, that's what I understand. I don't have any clear, and I mean, I would think that it would be so, because it's not only hypotension which affects organ injury. There are so many other variables. So if you have multiple variables for causing organ injury, added on to that, a hypotensive insult would definitely cause more damage. But I cannot offhand quote a study to substantiate my point.
Thank you, Satyen, for that response. I'll just go back to my first slide, which was mentioning some. I have to go back 1 minute. Yeah, we are there. So can we go through these questions, if you don't mind? Dr. Nibedita?
Yes, sir.
Are you happy? See, I'll take up the first question. All of the following are dynamic indices of preload except one, and why do you think that is the correct answer?
Yes, sir. The answer is that the except is left ventricular end diastolic volume, because what happened, the stroke volume variation and the pressure variation and the systolic pressure variation, these all are the dynamic indices of the preload. Because as one example you can see, the pulse pressure variation is the marker of the position in the Frank-Starling curve. So yeah, as you know, if there is increased preload, increases the pulse pressure, this pulse pressure variation decreases. So these all are the PPV, SBP and SPV. They are the dynamic indices of the preload as per the variation it occurs, but not in the left ventricular end diastolic volume.
That's right. That's right. I will go to Dr. Bhupesh. Bhupesh, IABP inflation is triggered by which of the following events in the arterial pressure tracing? Is it anacrotic notch, dicrotic notch, diastolic pressure, that is the least pressure in the arterial waveform, or the peak systolic pressure?
Answer to this is dicrotic notch on the
Yes.
arterial pressure trace. And this is because, as you all know, this IABP, that is intra-aortic balloon pump, is basically a mechanical assist devices which works on the principle of volume displacement by inflating the cuff, which is placed in the descending thoracic aorta, proximal part of the descending thoracic aorta. So you need to inflate cuff during diastole, and the dicrotic notch coincides with the closure of the aortic valve. So
Yes.
when you inflate at that time, it displaces blood to the proximal part of the aorta and increases the diastolic pressure. That's why increasing the myocardial perfusion pressure. While it deflates during systole, that's why decreasing the afterload. So it increases the diastolic pressure and decreases the afterload by inflating in the at the time of diastolic notch and deflating at the time of systole.
Thank you for that. Next question goes to Vidya Patil. A flow track measures all of the following except which parameter is not measured by flow track? Yes, madam. Yes, madam.
Yes, sir. Before answering this question, I would like to apologize. I don't know what went wrong, sir. I was knocked off for nearly 23 minutes. And when I joined back, sir, you were talking. I don't know what went wrong. I think everybody got switched off for some time, but then you all logged in. I tried my level best to do so, but then it didn't happen, sir. I'm sorry about it.
No, doesn't matter. You are with us. That is more important. Can you take up this question?
Yes, sir. Yes, sir.
This
yes,
is
sir.
only for the benefit of the audience, not to. Only for the benefit of. We wanted to have audience poll, but that could not be arranged. So we have just put it here, so that the experts may give the answers for the benefit of the audience.
Yes, sir.
That is the whole intention.
Okay. The question is flow track measures all of the following except, and the answer to this question is the flow track measures all of the following except the pulmonary artery occlusion pressure.
Right. It doesn't measure the pulmonary artery occlusion pressure.
Yes, sir. Because flow track is a device attached to the peripheral arterial line, which is used to assess mainly the cardiac output and also the systemic arterial waveforms. Yes. And not the pulmonary artery waveform or the occlusion pressure.
Absolutely correct.
And to measure the pulmonary artery occlusion pressure, a pulmonary artery catheter has to be passed through a central venous line.
Absolutely.
That is the reason, sir. It is a device attached to the peripheral. This flow track is a device which is attached to the peripheral arterial line.
Yes.
And it can hence measure fluctuations in the arterial pressure, the heart beat-to-beat variation in stroke volume.
Yes.
And the cardiac output, which is product of heart rate into stroke volume.
Yes. Thank you for that response. Then we go to Dr. Vivek Dave. Vivek Dave, can you please tell us which one of the following equipments or tools will tell us about the extravascular lung water? Is it flow track, esophageal Doppler, IVC diameter, or transpulmonary thermodilation?
Yeah, thanks a lot, sir. Finally, I got my time to speak over here.
Thank you.
Because of the in between there was some technical issues regarding Dr. Vidya Patil's, so I could not able to introduce you, sir. But so back to the question is here is extravascular lung water may be determined by one of the following like 4 options: A, flow track, B, transpulmonary thermodilution, C, esophageal Doppler, and D, IVC diameter. So out of all, transpulmonary thermodilution is the very sensitive method to determine the extravascular lung water as compared to all of them. And other variables along with extravascular lung water like global end diastolic volume, PVPI, and all these things are also measured by TPTD. So transpulmonary thermodilution is the sensitive method to determine extravascular lung water.
Absolutely. Thank you, Vivek, for that. Back to Dr. Nibedita and other panelists.
Sir?
There's one more question there.
Oops, I just short of an answer to that. Okay.
No, I don't think any question is there.
Yeah, there
Role of
was one,
biomarkers.
and there was something about the role of biomarkers in organ injury prediction. Maybe I've given my answer in the chat box. Maybe sir could add to that.
Will you please read it out for us?
So what I told them, that there have been several biomarkers which have been explored with regard to target organ injury. Certainly the panel for the kidneys is mind-boggling. There's quite a few biomarkers which have been explored. But individually, I cannot point out any particular single biomarker which could be sensitive enough to definitely indicate organ injury. It would, if you are going for biomarkers, it would be wise to choose a panel of biomarkers which could actually tell you whether organ injury has occurred or not. Certainly, we have worked with NGAL, with cystatin, and none of them, I believe, is individually sensitive enough to tell us whether kidney injury has occurred or not. I would go for a panel, more than one biomarkers, maybe NGAL, cystatin with the metalloproteinases, things like that. But
Yeah.
So to add on to this,
Yes, Bhupesh, yes.
So there are different biomarkers for different kind of organ injury. But now this hypotension is also supposed to be a biomarker for sitting on the pathophysiological changes which leads into the organ injury. So hypotension itself is a biomarker. That concept is because hypotension itself doesn't cause problem. It sets in some pathological physiological changes which leads into the injury. So
what is your take on this hypotension prediction index, which has been developed by the Edwards group of trade company people? Anyone can answer.
I have worked with it. I have
Bhupesh.
worked with it for
Yes.
some time. They gave me a set of their transducers and everything to work with. They also left the HPI module with us to work with for about a month or two. I think like everything else in artificial intelligence, it's promising, but I mean, we did not conduct a systematic study of the entire device and the things which they had. It looks promising, but I think there's still a long way to go before we can completely rely on those parameters to predict hypotension. But I mean, that's what we thought about arterial pressure cardiac output monitoring when they came up with it. We thought it was, I mean, how can arterial trace be used to predict what the cardiac output would be like? And now it has been widely adapted, and so it holds our promise, but I think it has to be studied more and in different subsets of patients in different surgical. My general view was that whenever the blood pressure actually started dipping down, the hypertension index, hypertension prediction index went up. Now, if I'm looking closely at the monitor, I don't need the hypertension prediction index to tell me that the BP is now close to 65, and then in the next 5 minutes, it's going to go below 65. So that way, but then again, I have not conducted a systematic study of the device. So I'll probably, you know, that kind of a systematic study would be required before a final judgment could be passed on the HPI. But I think Dr. Thomas has done a lot of work on it. He seems to believe it's quite useful. I
have used in heart surgery, but the thing is the machine cannot predict when the surgeon is going to lift the heart.
So exactly. So in cardiac surgery, it's virtually useless.
It's of actually it falls. I mean the hypotension prediction crosses 85 threshold. It goes beyond 85 when there is heart is lifted. That is after the event has occurred. It is telling us. So it has no.
Even with sequential volume loss and everything, it does go up. It correlates well when the BP comes down. The hypertension index prediction index.
It
goes
is
up,
simultaneous, but we need
simultaneous.
something with, yeah.
We need more than that. We need more than that, because if you're looking at the blood pressure and seeing it dropping sequentially, then I don't need an HPI index to tell me that oh, blood pressure is dropping 65 now. In 5 minutes time, it will be 60.
You mentioned about prospective studies. Now, what we should do is we should use HPI index, that is hypotension prediction index, when you are tapering inotropes in intensive care units. So the best advantage is whether we can fairly quickly turn down the inotropes or not. We should know by looking at the hypotension prediction index.
It has not been studied so
no,
much in the CC.
No, that is one area I'm just.
One area which has not been explored,
So any panelists and moderator wants to say anything? I think there are no other questions there. Before we wind up, any last comment? Vedita?
I think there was something Dr. Ratan was asking, is it only the mean arterial pressure that matters, or is it the cardiac output? Maybe sir could. In one of his earlier questions, he was asking, is it only the MAP or is it the cardiac output?
I didn't see the question.
That was related to AV sequential pacing. So,
okay.
That has already told us if we measure
Yes.
BTI and times the heart rate, it will be the cardiac output. Ultimately, it is the cardiac output which might.
Evident, because the cardiac output and the MAP might actually go in very opposite directions. So we eventually have to look at the cardiac output, but then it's not always that we get the benefit of directly looking at the cardiac output all the time. So.
Dr. Muralidhar, can I tell something?
Yes, absolutely.
Hemodynamic monitoring, as you
boss.
know, and all the topic today, which all the 4 topics are really very, very good topics, and it is also a difficult topic. And all the speakers, they have so nicely and so simplifiedly they have told, and we must give a big thanks to them for making the difficult topics to such a simpler way. Thank you very much.
Thank you.
Thank you. Thank you. Dr. Radhakrishnan is available. Anybody from ICA fraternity? If there are none, I would like to thank all the speakers and panelists for participation and contributing to the scientific content of this webinar. Particularly, I would like to thank Nibedita, Dr. Bhupesh, Dr. Vidya Patil, Dr. Vivek Dave, Dr. Vijish Venugopal, Satyen, Parida, Niranjan, and all the others who were participating. Thank you so much.
Thank you, sir.
We'll meet again sometime. Thank you.
Yeah,
so
thanks a lot.
It's been a pleasure being here.
For inviting us.
Yes, thank you so much.
Thank you, Vivek. Thank you.
Thank you. Thank you.
Thank you, Vidya. Thank you.
Yeah, thank you, sir. We are
Thank you
closing.
so much.
Thank you.
Thanks a lot. Bye. Take care.